We are here for a very, very important topic, a need of an hour. Today, we are talking about diabesity. And to introduce the speaker, can I please invite Dr. Monica Vasudev from US?
Hi, Saurabh, and thank you, everyone, for attending to today's CMAAO. And we are very, very excited to have a very special guest today. We are honored to welcome Dr. Purvi Chawla, a distinguished consultant diabetologist and a leading voice in diabetes care and clinical research. She is the Director of Clinical Research at Lena Diabetes Care, Diabetes and Beyond, and the Mumbai Diabetes Research Center. She holds key consultant roles across renowned institutions, including VLSR, the Clinic Bhartiya Arogya Nidhi Hospital, and BSES Global Hospital, Mumbai. She's a passionate researcher and educator. She actively contributes to global and national clinical trials and serves on several prestigious committees, including the Governing Council of RSSDI Maharashtra and the Executive Committee of AIAARO. As chair of the Diabetes and Women Interest Group of Diabetes India and founder of Diabetes Research and Solutions, Dr. Chawla continues to drive innovation and advocacy in the field. Her work has been widely recognized with numerous accolades, including the JPEF USB Diabetes Tech Innovation Award in 2022, the ACP Best Indian Woman Educator Award, and the True Wealth Health and Wellness Award for her dedication during the COVID-19 pandemic. Please join me in welcoming our esteemed guest, Dr. Purvi Chawla. Welcome.
Thank you so much. I remain indebted to IJCP, Saurav, Nishita, the entire team, and thank you for such a kind introduction to this morning as well.
So just before we make the slides live, I would probably make this session open for public since it is live, because it's a very important and a general topic. People can join in and ask questions in the question answers. If they want to join the Zoom meeting, they can come on 818-8591-1572. So thank you so much, and I will make the presentation live.
So while the presentation is going live, let me just say that this is a burning problem for all our countries together worldwide, and particularly in India, and particularly for women. Because the numbers are staggering, the prevalence is exponentially increasing, the incidence, and these are prevalent conditions throughout a lifetime. And hence, early intervention, aggressive intervention is the need of the hour. But that can happen only when we increase awareness, not just in our physician community, but also in people living with these conditions and their caregivers. So, today's session, I personally have kept it very simple. I want us to understand the pathophysiological link between the two, and then looking at the numbers, how staggering they really are, and of course looking at a little bit of management as to how to go about it. We are lucky we are now in an era where we have options to treat both one or and protect end organs also, to prevent the long term adverse implications of these coexistent conditions. But I think we can have a successful session only with great interaction. So I do invite all of you and all our esteemed physicians who have joined in today on the Zoom link as well as otherwise, to actually chime in and help a very good discussion and help to bring out the points that will make an impact throughout the country and worldwide. So the topic was very general, diabesity. And just to introduce, this is the dual epidemic of obesity and diabetes without a doubt. And this combined phrase of diabetes and obesity is actually just indicating that there is a very strong relationship between obesity and type 2 diabetes. It was coined first in the 1970s by, I think, Ethan Sims. And we know that obesity is a primary driver of insulin resistance, leading to the development of diabetes. And today, it is absolutely a global public health crisis affecting millions of our people worldwide from this aspect. Okay, so some of the risk factors for diabetes, genetic milieu, of course, the family history or diabetes or obesity contribute. And then there is the intervening aspect of an unhealthy or imbalanced lifestyle, sedentary behavior, high caloric diet intake, hormonal imbalances, sleep disorders, psychological factors like stress and emotional eating. All these contribute very, very avidly to diabetes. And health consequences, just to enumerate the key ones: cardiovascular disease, there's a massive increase in the prevalence of the same. We have increase uh, in the risk of diabetic kidney disease, liver disease, neuropathy, nephropathy, all the microvascular complications, and yes, obstructive sleep apnea. So the impact is multifold and affects, numerous organ systems throughout the body. Next, please. And these numbers are, nothing. They are just increasing every year. And the IDF 10th Atlas released recently at the IDF Congress in Bangkok, we know that not only obesity but diabetes is also increasing at a massive speed, despite all our awareness and intervening efforts. So we need to, you know, go all out and really intervene very, very aggressively, starting right from the earlier years, because this is impacting our adolescents, our children also, adolescents, young adults, and middle aged, and of course, the elderly. So, throughout the lifespan, there's a very high increase in the numbers, and like I mentioned in my introductory note, that definitely impacting women even more, because the prevalence of obesity is much higher in women, and diabetes is not sparing them either. So, this dual epidemic and India specific statistics are also aligned with the global increase, and hence, urgent intervention is something that's required. Next, please. And this is from a long time ago. In fact, this has increased to maybe not just one out of two a person with diabetes suffering from obesity or overweight. It's actually more than 70%. So type 2 diabetes seems to be driven very, uh, very strongly by the prevalence of overweight obesity. We know that every unit increase in BMI, which is a common measure of overweight or obesity, leads to multiple and a myriad of metabolic abnormalities, and type 2 diabetes is one of the most prominent ones. Next, please. The Asian Indian phenotype, the thin fat Indian, I think that phenomena is, it's repeatedly discussed, but I think it's important for us to keep in mind, because this can be very misleading. The BMI, at the same BMI that as that of a Caucasian individual, an Indian carries much more visceral fat, and which is actually the seat of inflammation and insulin resistance, and that leads to the manifestation as multiple metabolic syndrome components, or even just overt type 2 diabetes. Next, please. So this again, this famous photograph of Dr. Yajnik sir and Yudnik, which was clicked, years ago. just to show that at the exact same BMI of 22.3 kilogram per meter square, their percentage body fat was so different. So external appearances can be very misleading. You may feel that you're not at risk, but until you measure the internal parameters and also the waist circumference, you may be really highly misled. So you can see here that as compared to the Caucasian counterpart with a body fat of 9.1%, are very healthy Indian actually, and BMI of normal BMI had also body fat of 21 to 22%. So just imagine that when somebody is externally also obese, the percentage body fat is so high, and that is the real killer as far as metabolic abnormalities go. So Indian patients are diagnosed at a much younger age, have less generalized obesity, and can we go back a slide? Have generalized less of generalized obesity like I just showed you, and thinner limbs as well, but have greater central adiposity and thus are more insulin resistant than patients from not just UK but any Caucasian counterpart or anyone else worldwide. Next, please. So, in your clinics, you can see a wide spectrum of phenotypes, and they all may be equally prone to diabesity. You may see somebody malnourished or lean, or thin built with a nice big tummy, or centralized obesity. You may have somebody normal weight, you may have somebody normal build, you may have somebody overtly overweight and obese, or somebody morbidly obese, and the risk of each of them to diabesity is equally high. So I think that's the point that we all need to take home today, that there's no assumption here. It's actually something that needs to be measured, and something that needs to be kept in mind, because a lot of people themselves feel that they are healthy, but they may be harboring a lot more fat within, which is far more harmful. Next, please. So, yes, our objective today is to learn the link between obesity and diabetes, because a lot of overweight obese people, I've heard them say clearly that, oh, yes, I have a little extra weight, but I still don't have diabetes. Well, it's a matter of time, because these two conditions are very closely linked. Particularly, type 2 diabetes is really driven by overweight obesity, and the connection is primarily driven by this the way the excess body fat impacts the body's ability to handle blood glucose. And the reasons very largely are insulin resistance is increased, lipotoxicity, which means excess fat that leads to excess fat accumulation in key organs like the liver, the pancreas, the muscle, and that also feeds into increasing insulin resistance. And then this fat accumulation in the different organs of the body, which triggers chronic inflammations and triggers the release of inflammatory markers such as cytokines, which will further disrupt the insulin signaling. So this is an overall model linking diabetes and obesity, and there is a common dependence on insulin action and secretion in peripheral tissues and brain, which is impacted by the presence of this. Next, please. So while we are looking at this impact of excess weight on diabetes progression and complication, let me remind all that abdominal obesity is actually the main culprit here, which may manifest as hypertension, pre-diabetes, or diabetes itself. And then eventually you have atherogenic dyslipidemia as well. But all this is not just limited to it. We have ramifications in the form of impaired kidney disease, impaired kidney functioning, or fatty liver disease, or metabolic dysfunction associated steatotic liver disease, as it is now called, MASLD. You may also have cardiovascular manifestations like not only coronary heart disease, but also heart failure itself. obstructive sleep apnea, polycystic ovarian syndrome, sympathetic activation and tachycardia, hyperuricemia, and chronic inflammation. So, all these put together are the complete or the perfect metabolic storm in the body, and it may lead to increased mortality from all causes. Next. Insulin and insulin resistance are the key underlying pathophysiological markers, because when there's obesity driven insulin resistance is just that excess visceral fat leads to chronic inflammation, increased release of free fatty acids, and thus impairing the insulin signaling. Insulin resistance is also the hallmark of metabolic syndrome, which disrupts these processes, causing reduced glycogen synthesis, impaired glucose uptake, and inappropriate lipolysis despite the compensatory hyperinsulinemia. So, in other words, when even patients get their fasting insulin levels done without even any of us suggesting them, they are very confused. My insulin levels are so high, and yet I'm developing, I'm overweight, obese, or developing diabetes. And why is the reason? This is the exact same reason that despite the compensatory hyperinsulinemia, which is increased insulin levels, they are non-functional, which means there is increasing insulin resistance in the different organs of the body because of the fat and inflammation, which is the underlying, uh, it's the underlying milieu in the body, which is giving rise to all these different metabolic syndrome components like increased insulin resistance, hypertriglyceridemia, increase in the BP, and decrease in HDL. And eventually they feed into, and all this with dysglycemia, they feed into the process of atherosclerosis, and probably leading to cardiovascular events as well. Next, please. Moving on, at the level of the pancreas. Now, this is also important to understand, because we know, I'm not digressing, but just to remind you all that the twin cycle hypothesis, with excess caloric intake leading to excess deposition of fat in the liver, then the spillover to the pancreas, and that seems to be the underlying mechanism of diabetes. So, yes, it's exactly right that beta cell dysfunction results from the pancreas trying to compensate for the increasing insulin resistance, leading to hyperglycemia at some point. So, it's the adipose tissue with the inflammation, which impacts not only the different peripheral organs like the liver, where there is increased gluconeogenesis and increased fibrinogen, at the level of the muscle, where there is increase in the insulin resistance. So there's peripherally increasing insulin resistance, but at the level of the pancreas, the pancreatic islet cell is attacked. There is beta cell hyperplasia. There is increased insulin release. There's increased oxidative stress as well. But the beta cell inflammation ensures that there is actually, this insulin is of no use because of the peripheral insulin resistance, and eventually there is beta cell dysfunction, loss, and impaired insulin secretion itself, and all this together manifests as clinical type 2 diabetes. The adipokine imbalance, this is also very important to remember, because it's the fat that is triggering the inflammation, and there are different levels, or there is alteration of the adipokines, which is the leptin levels, adiponectin, and the resistance in the brain and in the liver and in peripherally also, which alter the glucose metabolism. So we know overall that when there is increased fat mass, there is increase in the adipokines, but a dysregulation of the same at the level of the brain impacts the appetite. At the level of the liver will impact the steatosis, or the fat accumulation in the liver, and we know exactly what that leads to. There's also impaired insulin secretion There's impaired insulin sensitivity peripherally, and also in terms of the arterial tree, there is increase in the atherogenesis, and eventually leading to a cardiovascular adverse outcome. So again, this is just to sum that excess caloric intake and decrease in the physical activity that triggers off a whole lot of inflammatory cytokines and inflammatory milieu in the body, which again feeds into neurohumoral activation, chronic inflammation, insulin resistance, and gives rise to diabetes, the different components of metabolic syndrome, namely increase in the blood pressure, dysglycemia of various levels, eventually feeding into diabetes, leading to endothelial dysfunction and cardiovascular disease. Next, please. So all these are just graphic much better that there is a very close link between the two, and this can we now that we understand this close link and the pathophysiological underlying mechanisms, we can actually make an impact or make a difference in the lives of our people. But who is the first one to actually do that? And this is where primary care physicians also, and all of us with increased knowledge, increased awareness, that as we are the first point of contact for our patients, we can help with the early detection and intervention, preventing further complications of the disease. Detection and intervention, preventing further complications of the same. I told you what a close linked condition diabesity is. It's almost, intertwined. It's the chicken and egg. It's almost difficult to tell what has started first, but it's the coexistence which further magnifies all the risk for complications. So, yes, primary care physicians will definitely ensure regular follow up and a holistic management. It's also cost effective to diagnose this condition early, which reduces further hospitalization and healthcare costs, which the person living with the condition bears himself or herself in our country. We know there's very little insurance coverage uh, for the citizens, and this is where we can make an impact because we diagnose the condition early, we intervene early, and then we stop it from further complications which lead to hospitalizations and healthcare costs increasing. So patient education and empowerment is key, where we guide them with lifestyle changes, medication adherence, and self monitoring as well. And coordination with specialists is very, very important. It may be primary healthcare or it may be one of us as well, but referral at the correct time to cardiologists, nephrologists, or bariatric surgeons, endocrinologists, dietitians, it's all a multidisciplinary teamwork here. So we need to understand the role of different colleagues at this point and see who can help the patient most and at what frequency. So, addressing health disparities definitely will improve access to care in rural and underserved areas. And we need to, at the public health level, there should be community based programs which will help in all the things that I've just talked about. So, overall, we need strengthening of obesity and diabetes management in primary care because that is ultimately going to help us reduce the disease burden and enhance our outcomes. Next, please. Strategies, early screening and diagnosis. And forget that I'm just talking about primary care, this is applicable to all of us. So identifying high risk patients through the BMI screening, blood glucose monitoring, and also metabolic assessments like the waist circumference or the lipid profile or even the BMI itself, and other aspects are very blood pressure and other aspects are very, very important. Lifestyle interventions in terms of dietary modifications, exercise, and behavioral counseling are first line therapies. But let's not shy away from using pharmacological and interventional options as required or as indicated, because today we are in an era, a very exciting era, where we have multiple drugs to choose from, where we want to, and multiple procedures also to choose from as appropriate. Regular monitoring and prevention. Today, this increased continuous glucose monitoring also in diabesity, because that helps us to understand the impact on the blood glucose in real time, with different lifestyle changes, with behavioral modifications, and also medication impact. So let's understand that long-term monitoring and prevention in terms of management of weight, glucose levels, and complications effectively is very important. So let's empower not just our community, but the primary care level also, as well as those living with the condition, with evidence-based approaches to manage obesity as well as diabetes very effectively for better health outcomes. Next, please. Screening and diagnosis. This is for any of our clinics. This approach is reliable and gives us insights into lifestyle factors which affect the metabolic health. So, in terms of health parameters, physiological and body measurements definitely will help in sort of getting the patient into the care circle, so to speak. And further monitoring, further interventions will help to track the patient and the progress in that particular patient. So, early diagnosis is very important, screening is very important. And some of the methods are just listed here pictorially, that make sure the waist circumference, the hip circumference are noted at every visit or every contact with the patient. The blood pressure is noted, the pulse is noted, and a certain basic blood tests are also done, just like blood glucose testing and also blood lipid profile workup. Next, please. Obesity assessment. Well, we can argue on this particular aspect, but BMI still remains one of the very standard measurements for obesity. And today, yes, the times are changing. We are trying to get more and more simplistic methods like even waist circumference monitoring, but still BMI remains one of the standards. So let's not shun it away until we have much easier options and much more standardized markers to to categorize obesity. And yes, there are different classifications come up, there are different scales coming up, but yet BMI is a great indicator on a mass level. So it's not that I'm pitching for BMI, but at the same time, I'm not dismissing it. And I think we all should be aware of the limitations of BMI, but at the same time use it as appropriately in our practice. So you can see that uh, uh, for the Asian population or the Indian population, yes, we our cutoff ends at 23, and from 23 onwards, our categories of overweight begin. And then at 27.5, we begin with overweight and obesity itself. So waist circumference also, these cutoffs are very standard, that more than 90 centimeters or 36 inches for men, and for women, excuse me, Anything above 80 centimeters or 32 inches is harmful or considered as central obesity. Uh, Body composition analysis, wherever possible, should be undertaken without any hesitation, because that fat percentage measured, the muscle fat, the muscle mass, and the visceral fat composition is very important again for the patient or person living with the condition also to know what his or her risk factor is, right? Because we just talked about how misleading external features can be. In terms of diabetes diagnosis, we know the global standards in terms of OGTT or fasting blood glucose or HbA1c and even random blood glucose testing. And we know the different cutoffs for the same. They're all listed here on this slide. They can be very, very well used. This is standardized, recommended by our very own RSSDI also, and also globally. And these can be used for detection of diabesity in our clinics. Next, please. Yes. So once we've gone through, yeah. So once we've gone through the basic assessment for obesity and diabetes in our clinics, the next to undertake are the biochemical testing, including metabolic and renal health, liver tests, and looking at the baseline parameters in order for us to intervene more effectively. It's also important to look at not just the diabesity components, but also look at the other comorbidities that may be very much present, like dyslipidemia or hypertension or sleep apnea screening. Like I said, again, continuous glucose monitoring is a great tool in diabesity also. It's not just for people on insulin, it's very much to for almost all categories of people living with metabolic abnormalities, to help us detect the glucose fluctuations, to understand the patterns of glucose, and to understand the impact of not just medications but also behavioral modifications on the glycemic movement in the body. And so the key takeaway is actually early screening in all our clinics or even at the primary care level to detect obesity and diabetes much earlier, thus helping us prevent complications and to improve patients' life, quality of life, and outcomes. Next, please. So, harnessing lifestyle as medicine for cardiometabolic disease, I cannot emphasize more on this. Tailored exercise prescriptions, nutritional supplements well given, a personalized recommendation for optimal well being, and stress management. These are very key parameters that, excuse me, that form a part of our management. And effective management is always combining everything together. It's not just lifestyle, but it's not just pharmacological, it's the complete package together. You also need to be physically active, you also need to eat healthy, you also need to probably take your medications on time and monitor progress from time to time. Pharmacological interventions today, they include, of course, the key drugs for obesity and diabetes, but also the other comorbidities that exist, like the ACE inhibitors, beta blockers, insulin sensitizers, antiplatelet therapy, and also statins. Metformin and natural compounds aid in prevention and risk reduction. Next, please. So, first line intervention or all lines intervention always includes lifestyle changes, right? And the dietary goal is the healthy plate method. I will not recommend any. Of course, we have evidence scientifically, it's proven that the DASH as well as the Mediterranean style of eating is associated with better metabolic outcomes. But as an Indian uh, household or Indian community and many others in the South Asian diaspora also, I will suggest that we need to really focus on the protein intake, because that is dismal. The minute you increase the protein intake or optimize it as per the body weight, definitely there is weight reduction also, there's improvement in the nourishment, and there is automatic reduction in the carbohydrate intake as well as optimal intake of fat. So the aim overall should be to lose weight or aid losing weight to the tune of 7 to 10%. Anything above 15% will help remission of diabetes also. But in the 6 to 12 months, the aim should be to lose about 10% of the body weight by reduction in the total calories, and then maintaining it with the healthy plate method, where one fourth is proteins, one fourth is carbohydrates, and then half is fibers and fresh vegetables and fruits, uh, at least 5 servings of the same. Next, please. In terms of exercise, again there should be a prescription for the same, because often we just tell the patients verbally that you just need to exercise and you'll be fine. It is not fine with that kind of a loose prescription, because neither does the patient know what to do, and neither does he or she take us seriously when that is given. So exercise levels assessed via questionnaires and trackers, with fitness evaluated through exams and consultations. This is very important. And you can remember the FIT principle, which is frequency should be at least 5 days a week. Intensity, start with moderate intensity, which means brisk walking or swimming or cycling, progressing to various different exercising, like increase in the intensity of these Zumba, aerobics, all these are high intensity, but starting moderate and going on to high intensity is very, very important. Next is the time that requires for this. It should be at least 150 to 300 minutes of moderate, or if it's very high intensity, then maybe the duration can slightly reduce to 75 to 150 minutes of vigorous activity per week. And type, yes, there should be a good combination of aerobic exercise and resistance training, and also balance exercise, which is very, very important in our elderly. And today we know that with increased longevity, there's very little we are actually offering that age group of individuals who may be suffering from diabesity. So including that, those balance uh, balance activities in terms of tai chi or yoga is also very important, and this can be explained to the patient, and they can be guided as to go to the correct center or the correct instructor for the same. Next, please. Now, cognitive behavioral therapy is equally important in managing diabesity, identifying thought patterns and triggers. And you may want to have a counselor on board for the same. Because patients often complain, I mean, they may be able to recognize with all the social media hoopla also about it, that yes, they have been engaging in stressful eating, but we need to develop some awareness and mindfulness towards that. So, using food diaries, hunger tracking to differentiate between actual hunger and emotional hunger is also important. Practicing mindful eating can be taught, and these are things that the patient has to slowly develop over time, but one has to be guiding them from time to time with respect to that. So, your educators, your counselors are equal important multidisciplinary team players for the same. Cognitive restructuring, where you replace negative thoughts with realistic positive alternatives. And behavioral strategies for coping without food are also important, like exercise, meditation, social activities. We are taking your mind off the food, hunger, cravings, and all the negative aspects that sort of bring you down. Next, please. Addressing psychological and social factors are equally important, because and always roping in a family member is also very helpful, because you are building a support system for the patient. So setting smart goals is important, because even though we are talking about so many general lifestyle modifications per se, we want to go in a very organized manner so that we can achieve the outcomes that we want. So SMART goals, meaning specific, measurable, attainable, relevant, and timely goals, is very, very important. With that, I cannot emphasize the importance of regular follow up or checkup every 3 to 6 weeks or months, and wearable technology, which is the use of CGMs or the smart watches, etc., can be very well harnessed to get us the right outcomes that we want. Next, please. Pharmacological management is also very, very, very essential, because we need to be able to guide the patients well. It's not just the lifestyle modifications, but it's the combination of everything put together that is going to help. And today we are in an era of the GLP-1 receptor agonist therapy, where we have single, dual, triple agonists also coming in, and we need to use them effectively. Don't make the presumption that your patients cannot afford that therapy. Let them decide what is priority for them and what is okay for them to spend on their own health and their achievement of good health goals. So these are some of the agents that are available, and they need to be harnessed, or they need to be used appropriately in the right patient population, with the appropriate counseling as to what to expect, what are the adverse events, how often they need to be monitored with the same, what are the key parameters that they can track themselves at home, and how often can they come to you in the clinic. Next, please. SGLT2 inhibitors, metformin, and GLP-1 receptor agonists all help to aid weight loss. And we know today's uh, session is not particularly on them, but there is emerging therapy also in terms of amylin analogs that are coming up. The dual agents are already on the Indian market, and worldwide they have been sold for a while now. We even have triple agonists coming. We have more of oral GLP-1 receptor agonists being introduced next year. So it's a plethora of drugs coming in with benefits in liver fat reduction, weight loss, diabetes, and whatnot. But we need to use them appropriately and teach our patients how to monitor themselves on that as well. Next, please. So the conclusions, and I'm happy because this will make some headway for good discussion. Early intervention is key, and timely screening and lifestyle modifications suggested will help prevent complications and also improve outcomes. Identifying the high risk patients, take it from me, every Indian, every Asian is at high risk, but particularly those with pre-diabetes and overweight are those who require proactive intervention. Multidisciplinary team approach, where physicians, endocrinologists, diabetologists are all working with physiotherapists, counselors, dietitians, and psychologists, which will enhance the outcomes. And a team-based care, definitely approach ensures comprehensive metabolic health management. So, with that, I think empowering patients through education is very important. Self monitoring, self planning the meals, behavioral changes for and motivational counseling enhances their adherence and promotes sustainable health habits. With that, just to remind you that yes, diabesity is really a global threat today, and it's not just in our waiting area, it's actually sitting in our consultation rooms, and probably we are not doing enough. So let's take this from our consultation rooms to out there in the general public and make an impact. I thank you very much for a patient hearing. I'm so glad all of you joined in, and many thanks to IJCP for convening this.
Before we can move forward, I would like to remember Dr. K.K. Agarwal. On this day, we have lost him 4 years ago, 17th of May. So I think because of him, we are here, and we are taking over all his legacy in terms of educating all our viewers, members, and CMAAO. So just remembering on this day, and we would like to open the forum for the question answers.
Om Shanti. Sorry, Saurabh, I was not aware. I knew it was a month of May, but definitely our respects to Dr. K.K. Agarwal. So he has been a legend in the field.
Absolutely. So we will open the forum for the question answers. Please go ahead and ask questions.
If I may, I wanted
Yeah.
to say thank you for a fantastic presentation. And I know you talked about it, you kept referencing it, and I think this is something that is interesting and meaningful for anybody Indian across the world. And you talked about the thin fat phenotype, and I think it's very eye opening. And given that the thin fat phenotype is common among Indian patients, how would you suggest screening and how would you change management guidelines to be adapted in primary care to detect and treat diabetes earlier, even with patients with a BMI? So how do you tailor to us?
That's a fantastic, very pertinent comments, Dr. Monica. And I know you, in your area of practice, you must be coming across so many South Asians and Indians in particular with this issue. So I think it just starts with increasing awareness in our waiting rooms itself. We can have posters and short videos playing where even people accompanying our patients can be made aware of this entire aspect, and they may be able to screen earlier than you telling them, or it can be a self approach also to screening. And again, starting with the waist circumference, I think it's such a valuable measurement, which is non-invasive, which is so simple. Somebody can even do it at home. We have the cutoff values all over the internet also, where they can look up if they are at risk. But I think this is an important aspect which needs to be done in every clinic. We probably don't spend that additional time doing anthropometric measurements unless and until they come into that category. But they don't have to come into a overt obesity or overweight category for us to actually screen them. And even a random blood sugar today can tell us so much about what's going on with the subjects. So I think these are at least two key parameters. It's also, there are several publications on one particular aspect where they say that your waist should be half of your height. This also has been published in the Indian population, and I think this is also a very key takeaway that we can remember to actually teach our patients and their families, so that they can be subject to early screening and then active intervention as well.
Thank you. So in summary, it's knowledge for our patients, it's knowledge for our clinicians, it's using easy methods to screen and then to address issues as soon as possible, but not specific to change guidelines. I think what you just said is perfect in the spirit of Dr. Kate Agarwal. What he did, what you're just saying right now is exactly in the same line of how he tried to promote health universally, globally, make it accessible. And I think it's very nice that you did your presentation today. Thank you.
Thank you so much. And I think the more complicated or the more layers we add to the guidelines, also, we lose the spirit somewhere. When we talk about, I think pregnancy and diabetes is one shining example of the same, because, every time we have tried to introduce the entire OGTT over 2 hours, trying to see that the patients are, fasting overnight and stuff, it has failed. And today India is an example of universal screening for gestational diabetes, The reason is we simplified the process completely. So that process includes an absolute non-consideration of the patient's fasted state, meaning the patient can be fasted or non-fasted, is given a certain glucose load, and one single glucose measurement is taken with a glucose meter. Not even a lab testing is required. That's taken 2 hours later, and that value serves as a diagnostic screening purpose. So with simplifying the process, we were able to achieve universal screening. And I think the same principle can be shifted to primary care across the world for diabesity as well. That we need to do just one or two things in the clinic, just make the patients also aware so that they themselves can actually do this. And it can be a fun thing for the kids also growing up, that oh, what is your waist, and how is it all measuring up, and they can always discuss with the doctor when they meet the doctor about the same. I think that's the key for me. I would love to hear all your views.
Dr. Ashley, please go ahead and ask your question.
Thank you. Can you hear me clearly?
Yes.
Thank you. Thank you so much for this very interesting concept. And I think for the first time I heard about diabesity, and I think it's an excellent terminology. So just one or two questions. So the first one would be, in South Africa, we tend to do the quickie test. And I think it's not worth the money, because if the patient's got is obese, with elevated blood pressure, as well as hypertension, diabetes, or a glucose that's elevated, I think it's quite, you don't have to go to a quickie test, because if you look at the guidelines, that's already an indication that you are insulin resistant. Then you mentioned something else, and also very interesting to me, is the elevated uric acid, as well as the tachycardia that one gets, because I've seen a lot of patients who doesn't have any uric acid problems, but have an elevated urate test on a kidney function, with a bit of tachycardia and overweight. So that actually, if I now thinking back and listening to what you said, that would actually also place that patient in a higher category of becoming diabetes, with the possibility of this obesity, diabesity that you have mentioned. Am I right? Thank you.
Absolutely. It's just you're absolutely correct. It's just that standardizing heart rates across the world, across populations, is not really being done. So, and again, it's very transient. So, it may be difficult as a screening test, but definitely if someone has sustained sinus tachycardia, uh, that's a given, complication of overweight, obesity. So definitely it would guide us further as to, yes, this patient should be worked up for cardiovascular disease screening as well, and should be under the radar for aggressive intervention as far as weight loss is concerned, or keeping the sugars under check is important in that particular patient. So you're absolutely right about it. It's I'm not particularly sure of the screening value of the same, because it's very difficult to standardize such a transient or a fleeting parameter, something that changes so quickly. It may be difficult to kind of lay down the ranges for the population, but keeping an eye on it is very, very important. I completely agree with you there.
He's a chairman for CMAAO. Dr. Chang, over to you.
Dr. Chawla, thank you very much for that presentation. I just want to ask, what are your thoughts on elevated uric acid? Is it a proxy marker for a lot of fructose intake, and therefore, tendency towards diabesity?
Again, absolutely right, Dr. Chong, and great to have you on the webinar with us today. Yes, I think that is an often ignored parameter, and I'm so sorry to say that most vegetarians, because this is an issue with India, that we have a sizable vegetarian community, and the minute they see that, oh, there is a uric acid increase, they stop eating the pulses and the dals, which actually are not really responsible for that increase in uric acid. But that misnomer and the connection with protein is actually hampering us and decreasing our protein intake further. So they need to take very good advice from registered, experienced, and expert dietitians who can guide them as to what are the real things to avoid for hyperuricemia, which is a direct cardiovascular disease marker, as you pointed out, and which often is increased with overweight, obesity, and is a silent marker because not all patients are worked up to look at uric acid as well. So, again, very important point brought out, needs to be monitored, but the correct dietary advice needs to be given to patients where they do not stop the other relevant protein intake to combat hyperuricemia.
Yes, thank you.
So
In fact,
can I ask a question?
yes, Dr. Bukhari, go on.
Thank you so much. First of all, I will like to give the tribute to the KK Agarwal. Due to him, we all are here since COVID, and I pray rest in peace. And then I have a question from Dr. Purvi Chawla. Uh, is this ratio of increase in the number of diabetes and in the obesity is in comparison with the increase in the population globally, or it is one side increase in the diabetes and obesity? This is the one question. Second question is that in spite of this, that here on this platform and other forum, everywhere there is literature, there is awareness, there is a, but why the number of diabetes increases? I cannot understand. So this is to you to give me the something to enlighten me about these questions. Thank you.
Dr. Bukhari, sir, you have asked $1 million question because this is what, I think everybody is really trying to address globally, that, why are the numbers increasing despite the awareness?
Yes.
I think it's the rapid shift in the lifestyles of Indians and South Asians as such, because
Even in Pakistan, Pakistan is becoming the number one spreading diabetes here in Pakistan.
correct, it's the huge intake. It's first of all our sedentary lifestyles. Secondly, a very high intake of processed foods, because we are just aping the West. We have forgotten that we actually knew how to cook. Nobody wants to, in the fast rapid lifestyle, nobody wants to cook at home, nobody wants to spend that extra time planning the meals where you can think of how much protein, how much carbohydrate, are we getting enough vegetables, and are we getting a right balance of everything. Nobody's thinking about that anymore. People want the fast food, some quick fixes, but really there is no quick fix for such a lifelong metabolic issue. So these are, and the stress. Today we are again, yeah, noting that there is increase in cardiovascular despite all the drugs and despite all the statins, antiplatelet therapy, the SGLT2 inhibitors, GLP-1. As much as you do to protect the heart, there is still early death from coronary artery disease just impacted by stress. So I think stress is also, sleep is deprived, constant Bluetooth, I mean the blue screen exposure. People are not leaving their phones before sleeping, waking up in the middle of the night and checking messages. It's just, a complete change in the way we lived. And then we complain about why this is happening, but I think the answers are obvious here. It's just a lack of acceptance. I think the awareness is there, but the acceptance is not.
And my other related question was either this increase in the number is due to increase in the population globally.
Definitely, methods of epidemiological surveys have also improved. India was always touted, like I'll give you just one example, that India was uh, reported to have only 79 million people living with diabetes. But actually, with surveys conducted across every state, the number came up to 101 million in the same year. So, we were actually missing out on 22 million people living with diabetes itself. So, definitely, yes, the epidemiological methods have also improved over time. So, we are seeing a rapid increase. But I think also obesity has really increased.
Yes,
So,
thank you.
and that is driving diabetes.
Thank you so much. Thank you so much. Thank you so much.
Thank you, sir. Thank you, sir, for initiating this discussion.
Thank you so much.
Dr. Chawla, what are your thoughts on, because of the CGMS, continuous glucose monitoring, what are your thoughts on GLUT4 receptors in the cells?
Again, I think very important to look at insulin signaling, and that will help us, CGM will help us to understand the glycemic fluctuations in the body, plus also look at the glycemic patterns, look at any unrecognized hypoglycemia, importantly, and look at hyperglycemic peaks. So overall, we will have a very fair understanding of insulin sensitivity and insulin secretion also in the body with the same. But any further correlation, I am not aware of that with respect to the GLUT4 receptors.
Thank you.
Have more questions on the floor? In the time, we have one question on the social media which says that meal timing, portion size, and intermediate fasting is a very important aspect of uh, changing lifestyle and controlling the blood sugar. Can you show some lights on it?
Yes, absolutely. Meal timings are very important. And again, I think studies, there's enough evidence to show that sticking to the circadian rhythm, because that is a master regulator of metabolism in our bodies. Sticking to the circadian rhythm times, meal times with sunrise, and then not really overwhelming our digestive system as well as metabolism post sunset is important with respect to getting optimal metabolic effects. And intermittent fasting, these studies are very difficult to conduct. Any nutritional intervention or any this kind of an intervention, and to have a long term study is very difficult actually to conduct. But still, there is adequate evidence to show that uh, when intermittent fasting is employed, say for 12 hours or 13 hours, so 8 to 12 hours of fasting helps in regulation of blood glucose, hypertension, and even lipids. But anything beyond 16 to 18 hours actually aids weight loss as well. But the correct eating in the eating window is important. There are a lot of misconceptions with respect to working out also. Earlier, it was believed that working out in the fasting period is a no-no, but we know there's emerging science to tell us that working in the fasting period is all right, and then post-workout, the meals can be initiated. So yes, meal timings, there is no one size fits all. But overall, I can say that if you maintain the circadian rhythm, which is eating dinner early and not going into the late nights, then a lot of excessive caloric intake will also go down, and your metabolism will be revved up with respect to uh, good balance, metabolic balance within the body.
Dr. Chawla, I sometimes tell my patients that to move after food because the muscle can absorb up to 75% of the glucose load into the muscle cells and to be stored as glycogen. What are your thoughts on that?
That absolutely works. That works very well. There were studies earlier to show that even people on basal bolus therapy benefited from walking post lunch or post meals, and they were actually given that prescription that you wait for half an hour post the meal and then you walk on a treadmill for 15 to 20 minutes, or walk around in the house. In fact, we even gave this as a recommendation for those with gestational diabetes, because sometimes we don't want to increase their insulin doses, but yet we want the sugars under very tight control. So we just ask them to wait for 30 minutes post meal so that the food is digested a bit, and then walk around in the house.
We also there's therefore the role of the importance of sarcopenia as one ages, right? I understand from about 40 onwards, there's about a muscle loss of about a pound every year.
Totally. Sarcopenia is a huge concern in a country like ours. In fact, we are at the risk of uh, obese sarcopenic as well,
Yeah.
because that is much worse, because with the loss of muscle we have increased adiposity, which is again feeding into this burden of diabesity. So yes, sarcopenia, and then the importance of weight training or resistance training is very, very poorly understood in at least our countries, and that awareness definitely needs to change.
We're having a huge problem with the sarcopenic elderly in Singapore, especially after COVID, because a lot of them stayed at home and didn't leave their houses, and didn't move at all, and lost the muscle, and of course lost their brain because they didn't interact with all the people in the markets and all that. So we're having a huge problem here in Singapore with a few 100,000 elderly sarcopenic in their 70s and 80s. Huge problem.
Same here. It's the same here, and I think that awareness is so low. Uh, they only complain of weight loss, weakness, chronic fatigue, but they are not willing to increase the protein intake or invest in some resistance training, which will help build muscle and also the bones. So yes, huge problem, huge problem.
Yeah. This topic is
It's a Pandora's box.
such a gigantic topic, and the ramifications throughout the whole world. I tell you, whether from first world to third world is a nightmare everywhere. Trying to reverse this whole, it's like a tsunami. Amazing.
It is
I
the issue of the
completely
world.
agree. It's
So,
a
Dr.
massive topic.
So, Dr. Chawla, one more question I have. I think this probably would be the last question considering the time. Uh, People with hereditary obesity or fatness in the body, what time they should consider themselves screening, uh, and how do they want to go ahead with their life? Like what time they would screen themselves?
It's childhood. This is the time bomb we are sitting on. And there are massive, the government agencies, there are massive uh, programs and projects intended at school life, the adolescent life, the teenage years, and how to impact that. So as early as possible, as early as 5 years, you need to see that you're not over the 90 percentile of pediatricians need to be really well aware of this, because it's all starting as early as a mother's womb. And then with increased metabolic problems in pregnancy, there is early childhood obesity leading into the teens, affecting adolescents, and then young diabetes. It's as early as possible, I would say.
Unfortunately, I think in today's scenario, even in the schools, we have food which has been asked, like which is unhealthy food. So kids are getting attached to the food which they should be avoiding. People like the fast food restaurants, they're giving ads which can influence the kids. So I believe it's a very important answer that even when you are as a kid at 5 years old, you should start looking at what your kids are eating and get into a healthy diets. Nutrition is something which is very important. Dr. KK used to say that one kadvi, which is like a bitter stuff you should eat in one meal, which can control your blood sugar. Yeah. So, Dr. Chong, you want to say something?
Thank you, Dr. Chawla. This is a massive topic, and we're glad to have you back here again to continue the saga. But this is really a huge problem, and I think it's one of the biggest tsunamis, sweeping throughout, whether first world to less developed worlds. It's a massive problem. It's expensive to eat healthy, and all our lifestyles and the way the world is going doesn't help at all. In fact, accelerates it. So thank you very much for this wonderful session. And you see we've overrun our time because it's such an interesting topic. And thank you very much again.
I'm so thankful for this wonderful opportunity given, and thank you again for very, very insightful inputs.
Thank you so much, Dr. Purvi Chawla. With this note, we would like to take a leave, and thank you so much for giving such a good, insightful message. This presentation was very useful. With this note, we would like to close the session and miss you, Dr. KK Agarwal. Thank you so much.
Shanti, and it's a very special episode that we could do this on his anniversary itself. So, Om Shanti, and really, I'm glad that we were all part of this discussion. Thank you.